morning. I'm Sue Saunier. I'm the Stroke Education Coordinator, and it gives me great pleasure to invite our next speaker. Our next speaker is Dr. Mark Bayley. He's the Medical Director of Brain and Spinal Cord Rehabilitation Program, Associate Professor, University of Toronto, and Chair of the Stroke Evaluation Advisory Committee.
Thanks, Sue. It's great to be back, and thank you for inviting me to speak. I am a Queen's grad, so I feel like I'm coming home. I spent 7 years in Kingston. My son's in first-year university, so it was an excuse to go and bug him in residence and make sure that his room was as clean as he intended it to be. He had confused his mom, but I saw the real truth when I got there yesterday. Today I'm going to speak about some of the things that we're talking about, and I will sort of reinforce some of the messages that Dr. Huxley had, as well as trying to give you a provincial context to what's going on in stroke. And my overall objective, if I can get this working, is to I don't have any disclosures, is to sort of open this box which we call rehabilitation, and sort of understand what it is that goes on and give you a little bit of understanding of what are the key elements that we need to talk about using stroke as an example. And my specific objectives, I hope to use 3 stories that will allow you to understand what are the key principles of rehabilitation, to name the challenge. By the end you should be able to name the challenges in our current rehab system in Ontario, and you should be able to, by the end, discuss the evidence and rationale for some of our recommendations from the Ontario Stroke Reference Panel, and also describe some of the suggestions for implementation, which will be part of our discussion this afternoon. So, Ms. Jones is a 69-year-old woman who experienced the sudden onset of left-sided weakness and slurred speech while watching television. She thought maybe she had a little numbness, or she'd been leaning on her arm the wrong way, so she waited for 4 hours and missed the window for TPA, and then got admitted to one of the centers that are non-regional stroke centers and don't have a stroke unit. And her CT scan showed a right middle cerebral artery infarction. So in terms of rehabilitation, I come from Planet Rehab, so I apologize to those of you who don't. We think of the world in a little bit different way, in that we don't just think of all those body functions and structures. And when you think of it, a health condition at the very top, if I can use if it'll show up here it is. If you think of it, a health condition of any kind, whether it be stroke, congestive heart failure, myocardial infarction, they create problems. They create changes in body functions and structures. They change the person's activity level, and they change their ability to participate in their usual roles. And obviously, as we highlighted, there are environmental factors and personal factors that come into the degree with which this affects their functioning. So when we think of Ms. Jones has a number of impairments in body function and structure. She has a right hemisphere stroke, she has left hemiparesis and weakness, she has an ECG that shows atrial fibrillation, she has pneumonia, she's now developed pneumonia due to the dysphagia and swallowing difficulty she had as a result of her stroke, and when you look at it, she has right-sided visual field deficit. So when we think in rehab, so that's her impairments, those are her difficulties, but in terms of activity, just to introduce you to a concept which I think is important, we use tools which measure people's daily activities, whether you use the RIE tool or the FIM. In rehab, in Planet Rehab, we use the FIM. So I'm going to just quickly remind those in the room that the FIM consists of 13 motor items, which you can easily read. They focus on self-care, sphincter control, whether how you move around, and your transfers, and cognitive items, which consist of communication, social cognition, and problem solving and memory. And when we look at Ms. Jones, we can see that she's an individual, when you think of it, she needs some help with a lot of things. When each of the items are scored from 1, where she's completely dependent, to 7, completely independent, you can see that she's continent of bowel and bladder, but everything else she appears to need some assistance with. And when you add up the FIM score, it comes out to about 77. This is a fairly typical stroke patient in Ontario, pretty much around the average, okay? So I just want to talk about how her brain will recover, and because it's key to some of the underlying tenets to our recommendations as our panel. So basically, the brain recovers through two mechanisms. You have resolution of temporary factors, and you have central nervous system reorganization. So the temporary factors are to do with the acute ischemia and the edema. So if you look in the middle, if I can get the thing to come up again, here it is. You have an ischemic core, and that's where the stroke has damaged the tissue, possibly permanently, and that's the area that we are going to have trouble recovering. However, right around that area is an area which we call the ischemic penumbra, which the clot busters in the room, or the thrombolysis people, would really like to save. So what they do is they try and open that artery so that the areas that have not been permanently damaged can be reperfused, and we can save that area in the peri-infarct zone. And then you have areas that are normal. The thing with it is the brain can be suppressed because that area of the brain that's damaged or injured is connected to other areas. And that phenomenon is called diaskesis. So in addition to the swelling, the edema, the lack of perfusion, we also have the nerves being suppressed. And when we see this, we can actually see this on a SPECT scan, where in this area you have the stroke, where there's decreased perfusion in the area affected by the stroke. But if you look closely, you can see that the cerebellum, which is remote to the stroke, is actually hypoactive. So we know that a number of processes go on and resolve early after the stroke. In addition, we know that based on animal research and clinical research and MRI evidence, we know that the same things that happen when you learn a task like golfing, when you practice something with your hand, those same recovery things and those learning occurs after a stroke. And the mechanisms are it's very much the same. But what's unique after a stroke is that you have a lesion now. And so you have a limited substrate to work with. But yet still we can show, and this is work from Randy Nudo in primates, that if the person does not get any rehab after they've had a stroke, an induced stroke, and it's hard to use. I wish I could just walk up there, but I'll see if I can. If you look at this, this is an individual who got no rehab. You can see that the area for the stroke, the area that operates the hand, has actually shrunk. But this is an individual who did get rehab. The brain has reorganized to recruit new areas. And we can see this on fMRI. I'm not going to spend a great deal of time today talking about that. We can see this on functional MRI as well in humans, where the area that's involved in a task has actually expanded. And so when we look at the time course of recovery, we have the early days where they get resolution of the swelling, resolution of the problems with the blood flow, resolution of remote depression, and those go on for a few days to probably a couple of months, and then the brain can reorganize, and that begins in the early weeks and months. So, just to go back to our patient, as I mentioned, she has an ECG that shows atrial fibrillation. She needs to start on anticoagulation. Because she's not in a specialized stroke rehab center, she takes 15 days to get the referral out to rehab, and she's accepted on a Friday for rehab, but is not admitted until Monday because rehab units don't have access to labs and IVs and the things that she needs on the weekend. So, here's a question following up on Dr. Puxty's point. This is the question. If Ms. Jones is in bed for 15 days, how many days of exercise and walking, if she didn't even have a stroke, will it take her to return to her previous level of function? Pardon? 90. It's a bit longer than if she didn't have a stroke. It's estimated that it's 2 days for every day you're in bed. So a lot of what we're doing in taking somebody in rehab is actually reversing the effects of the bad acute care. Now, I think we already kind of said that, but I'm going to emphasize it, right? Okay, I'm going to be the provocative guy because because I tend to be that way, as Callie and others know. If the people in acute care don't mobilize that individual, the effects of rehab are partially to reverse the negative effects of the early hospitalization. Now, in an enlightened stroke unit where you have good care, we will do the things, the senior-friendly things that Dr. Puxby talks about, and we won't let that happen. So, in rehab, just to remind you of the principles, we can do a number of things with an impairment. We can eliminate it by trying to re-strengthen an area and hopefully recreate it. We can compensate for it by using adaptive strategies, working with your left hand instead of your right, working with your right hand instead of your affected left, or we can use devices like orthotics, and all of that probably involves some training. So rehab has a number of strategies, and the reason that the neurologists 30 years ago thought that we didn't do anything is because when they examined the patient and they looked at their impairment of their arm, they didn't see any change in the major impairment in some of the severe strokes. But yet, when you actually look what the person could do, they actually were functioning much, much better. So we have to have this idea of eliminating the deficit, compensating for the deficit, and training them. And here's the most important principle, which is in present, and I believe it's present in all rehab populations. We just have very strong evidence for it in stroke, because people have looked at this. So, we know that the brain is primed to recover, that when you have a stroke occur, that there's actually release of brain-derived neurotrophic factors and other factors that are stimulated by the inflammation of the stroke that actually suggest that actually come out right after the stroke. And that there is actually a time window when the brain is primed for maximal response to rehab therapies. And that delays are detrimental to recovery. And there is a clinical association between early admission to rehab and better outcomes. So what is this? In animal studies, this is Bernasky et al. What they did is they looked at early training of rats, and they're from Newfoundland, and what they basically began their training at 5 days, 14 days, 13 days, 30 days. And they put the control animals socializing but not having access to any training. And so what they found is that those who got into rehab or started their exercise in this very stimulating environment with the reaching and training, that they made marked improvement. But those who started at day 14 made moderate improvement, and day 30, they made no improvement compared to controls. So what do we do in rehab? We make people, what do we do currently? We make people wait. Not a good idea in terms of cortical reorganization in the brain. So if we look at this in humans, this is just some other corollary evidence. This is from Lau Cowra in Britain, and basically what he did is he looked at people who got into a stroke rehab unit or a stroke unit versus those who didn't. And you can see that in terms of what their percent of their discharge functioning, that the individuals didn't get to the same level if they started earlier. But here's the interesting thing that I always like to highlight, and Bob Teasel always likes to highlight. When you actually look at the amount of physiotherapy or occupational therapy the group got, the group that got the physiotherapy up front got the same amount as the people who got it in the long term. So over the long term, the people who were on a general medical ward got as much physiotherapy. So it's not about the amount of physiotherapy, it's about putting it in early. And so we actually can say that the people in the general medical ward got more. And so we know that we need to front load and get people moving as soon as possible. And so basically, the idea is that there appears to be a therapeutic window that we need to take advantage of. So one of the second points I want to emphasize is just about how do we do rehab research. One of the problems we are at now in rehab research is that we are at the point where it's actually probably unethical to deny a stroke patient rehab in some cases. So some individuals have, and it's not, so what some individuals in the US have done this study called the Post-Stroke Rehab Outcomes Project, where they looked at 6 centers and they said, okay, what are the key ingredients? They took minute by minute, they reported what the therapists did, the doctors did, and they found that when you look in the black box, the therapy intensity is an important thing. So what they did is the stroke programs with the most efficient outcomes admitted their people to specialized interdisciplinary teams. They admitted them earlier and more disabled. That's for those of you who work in rehab, and more disabled. Okay. they moved on to more intensive therapy. They spent less time in assessments. How many people work in rehab here? How many people would love it if their manager would cut the documentation they have to do in half? Okay. How many would love it if they exactly. So they move to high level of tasks early, so they don't, there's some theories around the BOBAth and neurodevelopment that says you have to progress, but these people actually moved to the higher level challenging tasks early, and they had well-developed outpatient services, okay? So that sounds a little bit like our roadmap, right? The intensity, the therapy, and task specific. So one of the problems we have, and we've convinced some people of this, and we're working on it as I go around the province speaking in different regions about this, is that the length of stay in hospital is not cheap. That the cost of having somebody in hospital, the base cost is somewhere around $200 to $300. Okay, so if you start there, or $400, you've got them in hospital just to keep them there. It costs you about $400. And so, when relative to a day in hospital for the nursing care, for the heating, for all that stuff, adding in an hour of therapy or 2 hours of therapy is relatively cheap. And the problem is that less than 20% of the budgets in rehab are therapy. And most people in Ontario get about 87 minutes or less of therapy on a day. So they sit in a bed for 22 and a half hours, or they sit on the unit for 22 and a half hours, not getting therapy. Okay, so if you were going to a store and the shelves were half full, or even worse, if they were 80% empty, would you go to that store? Probably not. Would you go to a cruise that only had activities for an hour and a half every day? Probably not. So this is the problem we have. And so increasingly, we're focusing on this intensity issue. And when we look at the American comparison, their length of stay is about half of our Canadian, and they have what's called the 3-hour rule, which means people get 3 hours of therapy a day. So here's the problems illustrated by Ms. Jones' case. First of all, we know from the data, this is from the Ontario reports, it's from the world reports, that specialized stroke units have lower complication rates, pneumonia, and a shorter length of stay. That we see that acute in non-organized teams, the acute investigations about what caused the stroke, the CT scan, all the stuff we really need, are not completed quickly in non-organized stroke units. We know that there's a lack of common assessments between acute and rehab, and we need to use some common language. And that we know that transfer from smaller hospitals is more complicated. We also see that, and for those of you who work in acute care, I understand this issue, because you probably have this issue. We have to wait until we've polished the patient to look really good for rehab to accept them, right? So we wait until they're perfectly rehab ready to start the referral process, and then we're not really pulling them out of acute care. So they have to be dusted up and make them look really good so that the rehab center will take them, because we know from the data that that's happening. So, so the challenges that's going on, we know that earlier rehab, she waited 15 days, earlier rehab associated with better outcomes, no admissions or treatment on the weekend. We know that we need to enhance the nursing skills in rehab to be able to tolerate the earlier people, and we need to increase the intensity. So, that's my one story. A lot of principles. The other ones won't have as many principles, but hopefully I illustrated the challenges with our current system. So the second case is Mr. CPA. He's a 62-year-old man who woke up with right-sided weakness and slurred speech. He waited again before calling an ambulance. Like a good number of our Ontarians do not arrive in time for the window, the TPA window, and he wouldn't have got it anyways because he had a thalamic hemorrhage. So when you did a CT scan, he has a right-sided thalamic hemorrhage and severe flaccid weakness on his right side. He had to be in the ICU for a hypertensive crisis briefly for a day, and he had a swallowing deficit, so he required a feeding tube. He gradually stabilizes and is referred for rehab. He has a very supportive wife who's involved in advocating on his behalf, but their home is not wheelchair accessible. So, just to reorient you to our impairments and disability again, this gentleman has a FIM score that totals up to 49. This is quite low, this is more severe. You can see he needs assistance for the vast majority of daily functions. but is perhaps cognitively a little bit better because he did not have as much cognitive involvement, but very significant severe. And so this leads us to the question, which is provocative and always good for a conversation, and I usually put on my flak jacket before I start having it. Should more severe strokes be rehabilitated?
Yes.
So, thank you for the answer, but I'll say with a proviso in a moment. Anyway, these are the patients who are the major contributors to ER and ALC and stroke. They improve to a lesser degree and at a slower rate. So the issue of lesser degree means that they still make an improvement, but they don't make an improvement that is different from that gets them to the point where they're completely independent. And we believe that the benefit of rehabilitation is often in the compensation and teaching people how to work around their severity and in reducing complications and improving discharge planning. So, and when you look at the data, it's, there's comparative trials, there's randomized control trials, and when you look at, this is the one that we love to cite, the Jorgensen, which is non-randomized, but it's a huge number of people. And when they looked and followed up people, the risk of a poor outcome of people with severe stroke who got into a stroke rehab unit or stroke unit was reduced by 86%. And that this benefit was sustained out to 5 years. 70% of them, 70% reduction in the risk of dying or being institutionalized. Similarly, Bob Teasel and the group at Parkwood have done some work on this, looking back retrospectively at their own cases, at those people who are admitted on day 56. This is a group that we don't even think should, are ideal, and they were admitted very late after their stroke. And even though their FIM was very low, between 46 and 70, they were able to get a 20-point improvement in their FIM, a very slow efficiency. It was over a large number of days with a mean rehab stay of 88 days, but still 43% of them went home. Okay? So if you think of it, if the outcome is going home and being home, the reduction in costs are quite substantial. So this is a provocative part of my conversation. Again, I warn you. Should there be slow stream? Okay? So also known as low tolerance in Toronto, we call it LTLD, typically occurring in complex continuing care. And the e-stroke data that we have suggests that it takes a little longer. So again, coming back to the intensity issue, the average person in slow stream gets, I'll talk about the data, less therapy intensity. And when we compared people who had similar FIM scores, they weren't completely matched. This is not a randomized controlled trial, as Dr. Bagg will point out. But when we compared people with similar impairments at onset, those who got into a more intense program got through in about half the time as those who got in to a slow stream. So the question of intensity seems to be important here. And when we actually look at the complex continuing care data at a provincial level, we notice that they received less than 30 minutes per day of each available therapy. So they tended to get less than 30 minutes, and not all of them got it. And when we look at the outcomes, we see that those with stroke who stayed in slow stream stayed about 2 months, 57 days, and this has remained relatively stable over the last 3 years. That 30% were discharged to long-term care, 18.5% were discharged home and with services, and 10% were discharged without services. So that suggests that about 30%, close to 30%, were discharged home. So the outcomes are not quite as strong as the reported in the Bob Teasel study and in some of the others. And so we suggest that we have to be selective about who we bring to slow stream. And so basically, the problem that's illustrated by our second case is that severe stroke patients take longer, but may have the greatest benefit from rehabilitation in terms of reduction in death and institutionalization. That CCC or slow stream does not seem to provide exactly the same benefits as the more intense rehab. And Mr. CPA is fortunate to have a caregiver. And the study that we get into trouble and Shalal always gets upset about, but we'll cite it anyways, is we've looked at, Bob Tiesel's group and Matthew and others have looked at who goes home after severe rehab. And the problem is that if they don't have an able-bodied caregiver, it looks like it's a very low number. So it's not that they don't have an accessible environment, it's the having somebody with them who can help them. And I'll talk about that when I talk at the end about how we can use the triage tool to help us to make some of those very difficult decisions. And not just make the decisions, but also have earlier conversations with individuals. So our third case is Mr. Noseby, and he's a 75-year-old widower who lives alone and presents with very mild right-sided loss of dexterity. And he waited, again, before calling an ambulance. It seems like a theme in our group here, right? And his CT scan shows a small left-sided stroke. He doesn't comprehend well, and doesn't express well, but he's completely independent in mobility, but we're not sure of how well his safety is in terms of his language impairment, okay? So when you actually run his FIM, you see that most of his impairments are in his comprehension and expression, and he's very, very independent in his self-care, okay? So this raises the issue of outpatient rehab. This individual, if he were safe at home, taken care of at home, and able to be at home, could probably be discharged home for outpatient rehab. One of the problems we have is that people with speech impairment do not get the intensity they need when they're discharged home. And so we often admit people who have a FIM of 100 with, as you can see, with this. So basically, when you look at outpatient therapy relative to a cost of a bed day, which we estimate in Toronto, I know the number is $650. So one bed day is $650. So if you took one of those beds and you closed it, and you took $650 a day, that times 365 days, that's the cost probably of hiring a physiotherapist, an occupational therapist, and part-time speech therapist. So this is not necessarily a big thing in comparison to the cost of a day in hospital. And we know from the data that there's a 30% reduction in bad outcomes. We know that it allows earlier discharge home, and that the estimated savings in preventing of bad outcomes is $2 for every $1 we spend on outpatient. And I'm trying to reverse the wave as I go around the province, trying to drum up and be controversial. But the first thing that is gone in most hospitals has been the outpatient rehab. So most hospitals have closed outpatient rehab. I won't talk about the union issues involved and the ease in which the outpatient rehab can be closed, but people have closed outpatient rehab, and that's been the first thing that goes. And unfortunately, that's short-sighted because it takes away and forces you to make tough decisions about who goes into inpatient rehab. So our provincial strategy is to enhance outpatient rehab. And Matthew's going to talk about what the cost is. We're hoping that with investments, we can move some of those people who have less impairment and less disability into this. So I'm going to talk now about our provincial recommendations. I have a few more minutes left to do that. And talk about some of the things you're going to see, and Matthew's going to probably talk about how it might work in your region, and Steve's going to talk about the challenges you face in your region. But basically, here's what we want to see happen in stroke care. And we believe this is appropriate for many other conditions, including your total hip plate patients, and a number of other people. The people really need to be mobilized within 24 hours. So people need to be mobilized, regardless of the condition. We heard that from Dr. Puxty. We can't leave them in bed, okay? In stroke, our target length of stay in acute care is 5 days for people with ischemic stroke and 7 days for hemorrhagic. That's what we're working with, and we're trying to work through it. So how are we going to do this? How are we going to communicate? You work in Smith Falls, you work in wherever, and you've got a smaller hospital and you want to move people quickly. We need to make quick decisions. So we're proposing that we use the Alpha FIM. The Alpha FIM is a 6-item tool that has been developed by the folks in Buffalo who developed the FIM to quickly assess the burden of care. And they're scored similar to the FIM, in that where 1 is dependent and 7 is independent. And you have 4 motor items: eating, grooming, bowel management, transfers to the toilet. And if you're walking, you look at what they're doing in walking to 150 meters. So it varies depending on what your status is ambulatory or not. And then there's 2 cognitive items, expression and memory. Okay, so this is a 6-item tool that we believe is feasible. We've used it extensively in Toronto. We have about 1,500 referrals now with using the AlphaFIM. We have good data on what it does and its properties. And we've also done some studies with the data from Hamilton and Trillium, who've also been using it. So here's the proposed triage tool, and everybody has a little bit of a variability in this tool, so I know that Sue and Corinne and others may have some different interpretations for your region, but here's the general thinking about how we're going about this. In general, if your AlphaFIM on day 3 to 5 is already scoring at 80, and there's no severe safety concerns, again, if I don't change this, there's no severe safety concerns, i.e. they don't have a severe neglect, a severe inability to communicate for themselves. This is an individual who would go straight to outpatient rehab starting within 2 weeks. Okay? And we've implemented this in Toronto. It works quite well. We've just had 12 patients go through our fast track. We've already cut 90 days in 12 patients off their length of stay in inpatient rehab and acute. So it's a really quick savings if you can access rehab quickly. If you do have severe safety concerns, you're going to have a short stay in high-intensity rehab. Here's the challenging part, and for those of you who are gamers in acute care, if the score is between 60 and 80 and the person meets the criteria, they're medically stable, their lab tests have been done, they've been investigated for their stroke, they move to rehab without question. Okay? So the gamers this is involving trust. If people are going to score, if we can ooch their score by 1, they go to 60, so we don't have to have any questions asked. If you do that, it's going to create problems. But on the other hand, if we can all work with this tool, that means that people can move very quickly to rehab, very quickly, because they're in the realm where they're right in the sweet spot that we want to treat. Now here's the part that's harder, is the part that are 40 to 60, more severe strokes. We want to start having conversations with people. And one of the conversations is that if your AlphaFIM is around 40, that means you need about 6 to 8 hours of care. Now when we look at the data for Ontario, even with the most severe strokes, the average person makes an improvement in FIM of about 20 to 25 points. So that corresponds to a reduction in care from about 6 to 8 hours down to about 4 hours of care per day. Okay, so the conversation I will have with the case, what we need to have with the families is, okay, your family member unfortunately has had a very severe stroke. And it looks like they're quite disabled based on the data we have and the assessments we've done. Based on review of thousands of people like you, we know that even with the best of rehabilitation, the likelihood is your family member will require still 4 hours of care a day or whatever. You can calculate it. I didn't put up a slide, unfortunately, because of time efficiency, but you can calculate roughly what the person's hours of care will be after rehabilitation. This is based on thousands of patients. It's not, let's use the the ostrich approach, put your head in the sand and hope they get better. This is based on thousands of people. We know that most people make about a 20 to 25 point change in their FIM, even if they're severe. So they can come to the point where they now no longer, they don't need as much care, they've improved, but they still need care. And so this is when you have the conversation with families about, I'm really sorry that this has happened, really sorry that you're going to need help, but you've been saving for a rainy day, you've been putting away your retirement, and guess what? It's pouring out there. So can we talk about things that will help you and your family to be able to take your family member home? Starting that conversation on day 3 to 5 will revolutionize the system, because people will have conversations so that the people can do renovations to their home, so that caregivers can figure out if they're going to hire somebody, so the problem is those conversations don't happen until day 15, day 20, day 30, day 40. And at that time, it's too late for us to hit the targets that we have for those people to be in rehab. Okay? It'll be too late for us to do the discharge planning that we need to do. So we're asking people to use a formalized discussion of breaking bad news to have these conversations. We believe that some people may have had a very stormy course, they may have had a complication like pneumonia, and they may be the group for whom we want to either bring them into rehab or we want to bring them into slow stream, and that's why there's that case-by-case decision about slow stream. But we want to have a conversation with people early about the reality of rehab. So that's where I usually get the flak jacket on, because it's a controversial topic that most of us have not yet this thing. We know that the data, this is draft, we know we might be wrong, we know the score might be 55 to 80, we know the score might be 50 to 80, but we're going to work with it and try and see how it works, and hopefully we'll get there. So basically, when we have, and this is part of the integration part that I think Dr. Puxley was talking about, when we have a philosophy of shared patient care, that people may recycle into the system. Some of the individuals, as we admit people more complex into rehab, more severe strokes into rehab, some of them, 5 to 9% of them are going to go back to acute care because of complications. If I have a problem repatriating them to my colleague in acute care, or if they're down the hallway and they can't get the supports from acute care, that's going to burden rehab because it won't be able to take care of the patients, and they're going to be much more cautious about taking them. So we have to have this idea of reciprocal care and developing the capacity to swap patients and move them. So we also have a philosophy of 3 hours of care. We're going to try and talk about that. Matthew will probably talk a bit more about that, and I don't want to go too long, so I'm going to emphasize that we believe that if we can do this, we're going to have a much more ability to hit targets. And I'm just going to introduce those quickly to what we call the Rehab Practice Group. We now have published this a number of years in our Ontario Stroke Report. Basically, if you take the FIM score and you look at the motor score of the person, you can break them into 2 groups. I'm starting at the far left side, those with greater than 50 and those with a score of 12 to 50. If the score is 12 to 50, let's go down the bottom side of this, then you can then crack them out into whether they're more mild, moderate, or severe, based on whether their score is 39 to 50, or whether it's 12 to 38. If they are lower and their age is higher, then they've got different length of stay. So each of these practice groups have characteristic lengths of stays and characteristic costs. And similarly, if you're a more mild stroke, it comes down to things like your cognitive score, your motor score, and your cognitive score. And we can break everybody out into a set of patients that now we can very clearly break down. Here's what's happening in Ontario, okay? When we look at severity, we see that we're doing really well with the moderate group. The moderate group of strokes are getting increasingly access to the rehab centers. Unfortunately, we're going in the wrong direction. We started in 2003 where 37% of the people admitted to rehab were considered severe, and now we're down to 31%. So we're going in the exact opposite of what we're talking about. So, and meanwhile, we've been relatively stable about the milds. Okay, so now we're trying to say, okay, so let's manage our rehabilitation by provincial length of stay. Okay, so anybody who's a CEO or a bean counter in the room, listen carefully here. The rehab practice groups are going to be the funding formula in the quality-based funding. Okay, so you will be paid probably starting in March based on what the rehab practice group you're in. So in other words, the length of stay and the costing will be according to this. So you have to start thinking in a new way, not about are my beds full, but how many case weights do I have? How many cases do I have? How much do those cost each? Okay? So basically, we believe that this is a more reasonable way to do this. And here are some target length of stays. Some of them are pretty rapid. I am astounded by the 1100, which is the most severe. In our center at Toronto Rehab, we currently take about 60 days for this group. We're aiming for 48. This is really fast. And so we're all going to intensify and work hard on the outpatients to try and hit these targets. And Matthew will talk further about these targets based on the rehab practice groups. So early supported discharge. Early supported discharge, we need to work on improving our outpatients. We sort of want to see 2 to 3 outpatient visits per week for 8 to 12 weeks to enhance our outcomes. So You might say, yeah, right, but we've been in rehab for 30 years, this will never happen. So, maybe, but I can tell you, there is a little bit of hope. So, a number of regions have already, as I mentioned, implemented the AlphaFin. A number of LHINs have actually already consolidated stroke care into hospitals with stroke units. So, in other words, in Toronto, we have 17 acute care hospitals, and with quite a business case that I just presented to you, with the 3 cases of the mild, moderate, and severe, we were able to convince the CEOs of the vast majority of hospitals that they would consolidate their care into stroke units. So, there are now stroke units there are no longer, as of December, there will be places where people do not go for stroke care. So in other words, when they get in the ambulance, they will be taken, if they're outside the window, even if they're outside the window for TPA, they will be still taken to a stroke unit. If they are coming back from a repatriation from a hospital, they will go back to a hospital that has a stroke unit, not one that doesn't have a stroke unit. So, similarly in Muskoka, North Simcoe, they've moved to have an RFP process where some of the hospitals have come forward and agreed to be the stroke units for the region. So this is happening. Even before quality-based procedures are put in place, this is already happening. The CEOs have already agreed to intensify rehab because the business case is if you intensify rehab and you concomitantly reduce length of stay, that you can save costs. And Matthew will talk about that. And we've talked about quality-based procedures and all of the principles that I've talked about. Early rehab, early mobilization, admission to a stroke unit, early CT scan, early diagnosis have all been embedded in what we propose as the quality-based procedures for stroke care. So as we move forward, those hospitals that don't offer those quality things that are in the best practice guidelines will be at risk of having less money per stroke patient. So there is very much hope that this can happen. So in conclusion, sorry I'm running a couple minutes late. Ontarians still take too long to get to stroke rehab, and they don't, severe strokes are not getting access, and when we get there, we're not getting the intensity, and people are mild stroke patients are being admitted to inpatient because there's not access to outpatients, and implementation of these recommendations that I provided with you and the quality-based procedures could improve outcomes. Thanks very much.
Thank you, Dr. Bayley. Most pointed, provocative questions, and thank you for bringing to life our opportunities for improving patient flow and patient outcomes.